testing two fractions in prostate, two fraction HBRT. Each of them is doing a prospective trial testing, randomized testing two fractions. Somehow single fraction prostate doesn't like single fraction. It doesn't work. Brachytherapy has been tried, SBRT has been tried. The outcomes are really bad. It just loves the second fraction. So I think it's going to settle down at two.
At two fractions?
And regarding 5, we are doing a randomized trial. We have accrued almost 420 patients now. We will know soon.
Well, I can tell you a lot of robotic surgeons will be out of their job if you can prove that two fractions work.
So
right?
these are the guys.
I don't want to know you. I don't like you. Okay, so I'm going to get in Abhilash now. So abiraterone and enzalutamide with RT and ADT, pretty much standard?
Definitely not pretty much standard.
Mhm.
The verdict is out for using abiraterone for 2 years in node positive disease. But enzalutamide with RT, I don't think there is any evidence.
If
for it.
abiraterone will work, enzalutamide should also work. Does it work like that?
I don't think it's so
Not good
easy to
enough?
extrapolate and say that you can just use enzalutamide.
So 2 years of, so this is what the guidelines are saying, exactly what you have said, that if you're giving RT, then you give long-term ADT and 2 years of abiraterone to all clinically node positive patients. You give these patients some local treatment. So there's a little bit of a hope for Srikanth and me here, that because they say that either radical prostatectomy. So it's not as if you can't do radical prostatectomy in node positive patients, because it's in the guidelines. So you can give do radical prostatectomy as well. And of course, all other therapeutic options are not in place. So guess what? He did have a robotic prostatectomy. So at least. So it was a grade group 4 disease, 35% prostate involved, PT3B N1, 1 out of the 22 lymph nodes was positive, no extranodal extension, PSA at 1 month is 0.07. What next? Anybody can take it. Node positive, margin negative, T3B 0.07.
Only one node positive.
Only one node positive.
And out of 22, that means it will be an extended lymph node dissection.
You did it.
Margin is negative.
Margin is negative.
And
What are you going to do about it?
Gleason 4 plus 4A,
Yes.
right? So there are 3 options. I would offer him an expectant management.
So these are the 3 options. Which one would you choose?
The third one.
The third one. Okay. Difference of opinion. Abhilash and Trinanjan are like, why did he get surgery in the first place?
Yeah,
and
very
now they are
true.
saying
What we
observation.
are trying to save now, even the node is positive. So this is just a time he will require whatever format, maybe early salvage RT, or later he will require hormone, he will require some form of a third agent. So are we trying to save anything by doing all
So
of
would
these?
you give radiation in
No,
this
so
setting?
this with one node positive, we can pretty well wait after all the data for early salvage. This is PSA undetectable. After surgery, we can pretty well wait for early salvage.
Okay, so what really happened was that 3 months 0.06, at 1 year 0.07. Everybody, the patient, the surgeon, everybody has their fingers crossed. Too early, absolutely. I think we just have time for one mini case, and I'll leave the metastatic castrate sensitive prostate cancer discussion to my colleague Dr. Puneet in the evening. So we'll do one mini case, because this happens only in India. I'm telling you. You will know more about it when you read this. We have 10 minutes for this. 16 minutes? Okay. We'll see. So, ma'am is not there. Where is she? Okay.
You're the only one who have been able to do that.
Right, I have 60 minutes. All right, 67-year-old male, mild lower urinary tract symptoms, no comorbidities, came from a rural part of India. PSA he's come now, PSA in 2016, 8.2 nanogram per ml. Read this very carefully. He had a 2-core prostate biopsy in 2016. And it was a Gleason 2 plus 3 prostate cancer, whatever it means. It was a Gleason 2 plus 3 prostate cancer. Had a bilateral orchidectomy with TURP in 2017. No other investigations were done. There is no MRI, there is no bone scan, nothing. A bilateral orchidectomy plus TURP. I told you this happens only in India. No other records are available. He's come today, mild urinary tract symptoms. That's it. The 2023, right, sir. And now this is how the PSA is progressing. 0.3, 1.7, and now 5.6. I can tell you that each one of us sitting in this room have seen these patients. Each one of them, each one of us, right? Right. So now you tell me, and you'll never get this in any case discussion anywhere else. What next? And it's open to everybody. So what we are dealing with is probably a gentleman who had a localized, low-risk CA prostate treated with a lifelong androgen deprivation therapy by a bilateral orchidectomy, and now the patient has a castrate-resistant prostate cancer. That's it. That's the only information we have. Castrate-resistant prostate cancer. Tell me. He is 67 now.
So you stage it.
Whoever picks up the mic first has to speak first. So you, Shrikant.
So we'll stage it.
Sorry?
We'll do a staging investigation.
Okay. What staging investigation do you want to do? PSMA PET scan? If he could afford a PSMA PET scan, he wouldn't have got a bilateral orchidectomy done.
So bone scan and a CT scan.
Yes. So he did have a bone scan and a CT scan done. And on bone scan and CT scan, there is no evidence of metastatic disease. सर ये तो रिप्रेजेंटेटिव नेट से उठाई हुई इमेज है सर, वहाँ पे मत देखो आप इसको. वो मत देखो, वो ऑस्टियोआर्थराइटिस है पैर का.
But Dr. Gagan, in your
Yes,
city,
fracture because of orchidectomy.
but Dr. Gagan, in your city and in this city, if someone is affording bone scan plus a CCT abdomen, might as well can do a PSMA PET.
Okay, so he
Might
had
as well do a PSMA
All right,
PET.
so I should have put up another image from the net. He got a PSMA PET scan
That is
done.
normal.
There is an uptake in the prostate, but nowhere else.
So I think the other important thing in this scenario, we want to see the rate of PSA progression because it is fitting into the definition of NMCRPC. So non-metastatic, if the PSA progression is, so that is the definition if it comes into the non-NMCR because a patient has now become CRPC, it has not metastatic. So sir, now this terminology is non-metastatic NMCRPC, and for that there is a data for this newer AR inhibitors. So that is one thing we can consider.
Correct. But what I would like to ask you, sir, is that all this data is for patients who have already received local treatment.
Yeah, so we have to extrapolate. We don't know what is the best treatment for this case.
So that is the question that I'm asking. According to you, what is the best treatment for this patient? Should the patient get one of these newer things? And then again, you're talking about a gentleman who got a bilateral orchidectomy done
Without
because he
the
couldn't
money.
afford injections.
So we consider for some time the prostatic bed RT if there is no as such obvious metastatic disease. But with the current, the cost of the endotomy has come down to around 18,000.
So my question for you, sir, before I move on to Ranjan and Abhilash, is would you consider this patient for enzalutamide? Yes or no?
If affordability is not a question, I will discuss with my radiation oncologist colleague. If they are comfortable giving the radiation, I can keep it reserved for the next progression.
Great. Trilanjan, Abhilash,
So this is like
are you going to give any local therapy to this
This is
patient?
like M0 CRPC. So we don't have any proven data. There are some, if I remember right, some track trial, stop trial, and I guess from UK only. So they're trying to test the local therapy role.
You are
in
never going to
M0.
find this patient in UK.
CRPC.
So you
This
have,
we
we have to
definitely
figure
find.
out
This
our
we
own
definitely
trial.
find. Okay, coming back to that, then because if a PSMA done is no disease outside the prostatic bed, we might as well offer the radiation as a local therapy. Because anyhow he is not going to afford all these other fancy treatments. So why not?
Do you-
Even
okay.
if he is going to afford.
Okay,
even
so
if he's going
let me put it another way. Abhilash, do you think that this patient has a chance at cure?
So my stand is very clear. I don't believe there is any evidence for the role of radiation therapy in this case. So I would actually ask my surgical colleague that is he willing to operate?
if I am your surgical colleague, I'll tell you I'll run away so far that you'll have to catch a train to catch me.
So I think it's only Amit sir. The patient is left with Amit sir, and I think whatever he decides.
So
Gagan.
okay, so let me ask the audience.
Yeah,
Let me
yeah,
ask the
yeah,
audience. Yeah, just 1 second, sir. I want to ask the audience, how many of you think that this patient still has a potential for a cure? Raise your hands. Okay, so at least I would say 40% a potential for a cure, right? 40% people think that there is a potential for cure. So the only way that he can achieve cure is either surgery or radiation. Shrikant, will you operate him? No, Shrikant is not going to operate him. Abhilash, will you irradiate him?
I'm not going to irradiate.
Oh, he is not going to irradiate. So what do we do?
Exactly.
Sir, please. Sir, please.
So,
We've already done so. It's localized disease.
so
Localized disease. There's no evidence of spread outside the prostate.
well, this is a classical case of HSPC going to CRPC. Only thing is that this is M0 at this point of time. So whatever you give, whether you give local treatment or not, this is going to herald a systemic relapse sometime sooner or later. It might be there now, but you're not able to catch it on PSMA PET. That is a different story altogether, because he has had a honeymoon period of about 7 years. So whether you give local treatment or you do not give, that is not the point of contention. The point of contention is that you have to supplement a systemic treatment after it.
Right, sir. So, sir, please.
I think it's interesting. It's not one of the odd situations we do get in tertiary centers. These cases on and off. It is the surgeons, it's the urologists, in enthusiasm, they do these kind of surgeries. I think he never had a complete, a standard kind of either local treatment or systemic treatment in this case. I think we have to start from scratch now. He's 67. We don't know what's the proper staging. So I think crack on with having a biopsy first. Get a biopsy. Maybe with that amount of sort of complete androgen ablation, the biology of the disease might have changed completely. So he may have an NPMRI. He would have a biopsy of the prostate. And then, as it's been said, I think you can afford to get a PSMA PET scan. So start as a fresh.
Got it,
And
sir.
then take it further. I think this is probably an aberration or accidental treatment he has.
So let's take it from there. So biopsy shows a Gleason 3+4 prostate cancer. The MRI shows localized disease. PSMA PET scan is negative. What should we do?
I think you can offer him a chance. He's 67. You can go ahead and do radical.
So how many of us think that the patient should get some local treatment? Now suddenly it's 80%. There's just 40% was saying that there was. Oh wow! So we've made a difference here, right? How many of you think?
See, in the good old days, people used to do TURPs, just so randomly. But initially, our experience with radical prostatectomy was post-TURP and sometimes post-even open prostatectomies. So I think there is a chance.
So
67.
how many of us think that in this situation radiation would be a better option than surgery? How many say that surgery would be better? Wow,
is
no,
quite a
half.
bias,
So
I
some
think.
local treatment. How many say that he should be given enzalutamide or abiraterone upfront,
No.
along with surgery?
No.
How many say that it should be given only if there is a rising PSA after the surgery or radiation therapy?
These are the equivalent.
So I think we have our consensus here. So this patient
Gagan,
should, sir.
I want to make a few points. The conference itself is for Indian perspective, and this is a classical Indian case. Thanks for putting this case up. Moving forward, at some stage, we have to start, not putting patients into boxes. It's a very common attitude of all of us to classify, reclassify, box things up, as in this is NMCRPC, this is CRPC, HSPC, and this and that, which is very true in a very ideal setup, but we know where we are living, our setup is this. It's more important to take the patient in its own merit, the disease in its own merit. There is a disease in the prostate, assumption the PSMA PET that you said, take the disease in its own merit, considering the fact he hasn't had any local treatment. It's common sense to just treat it locally. Whether you do radiation or surgery is a different matter. And secondly, surgery is not a sin. You were saying that I'll run away from sin. There's no need to run away from it. It's equally as effective as surgery, as radiation as well. So we have to come out of this habit of boxing things up and start looking at it in a bigger picture.
Dr.
I think it
Gautam.
was more related, my comment was more related to the fact that probably in this situation, I wouldn't, like he's been on hormone therapy for 7 years, so we don't really know what the planes would be like. And secondly, if somebody goes through the process and the morbidity of surgery, I would say that it's a little bit difficult to face the patient when within 2 or 3 months you find that the PSA is rising again and you don't have much options left because the hormonal therapy is already being given.
Right. In our experience, doctor, when our hospital first started, 80% of the patients were like this. So we do have a small series of these patients which we audited, whom we treated with radiation therapy. And the 4-year biochemical control was about 60%.
Excellent.
So it's
just
not
with
bad.
radiation.
Yeah.
Just radiation.
Yeah.
No abiraterone, nothing.
No, nothing.
Awesome. That's excellent. And I think that's genuine Indian data, and I think we should give a round of applause for that.
To add to that, Gagan, this is
Post-orchiectomy. Yeah, it's post-orchiectomy.
Dr. Gagan, you have 4 minutes to.
Oh, I'll wrap up in 2 minutes. I turned around, I saw you, I knew that I had to get out of this place now. Okay.
This is exactly what we should be doing. We also have a slightly larger than a small series now, probably 30, 40 patients, and I'm sure in each of our practices there will be 5, 10 such patients. If you have such patients, please get in touch. We must collate and we must get the answers very soon. So this is
Absolutely.
why Sogo is there.
Excellent. And I'm going to take 2 of those last 4 minutes to thank and shake the hands of all my panelists who have done a fantastic job. I think we are going to stop now unless there are some final comments that the panelists want to make in any of the cases or any take-home message for all of us. None, sir? Yeah, please go ahead.
So this is to you and to the panel that we are all debating radical prostatectomy versus RT for locally advanced disease. Majority of the data for neoadjuvant hormone therapy in context to the surgery tells us one thing, that we get better negative margins. Sir, is there a data where hormone has been continued in adjuvant setting like radiotherapy?